esophageal motility, and a confirmation that you're actually dealing with gastroesophageal reflux disease. And the gold standard for that is a 24-hour pH monitoring test, where you actually measure acid concentrations in the stomach with a tiny little catheter that's left in the esophagus, You walk around with a little tube down your nose that's sitting in the esophagus, and you walk around with it for 24 hours. And while you're walking around with it, you have a little box, and you hit a button every time you have symptoms, because you want to make sure that the symptom that you're having matches with actual reflux. And you have to have concordance in that to really be a good candidate for a fundoplication.
Men and women, do they get it equally? What age groups get this?
So again, the most important thing about reflux disease is that it's associated with a high-fat diet and obesity. Now, there are specific foods that make you more prone to reflux. And those foods, if you can just imagine, a really nice meal with a chocolate dessert, a little coffee at the end, because the caffeine products will cause the lower esophageal sphincter to relax, and chocolate does that too. A high-fat meal sits in the stomach longer. It decreases gastric emptying. Those types of foods make you more prone to reflux. Laying down right after you eat obviously changes the mechanics, and if you have reflux disease, the first line of therapy is lifestyle modification. Change what you eat, lose weight, and don't lay down after you eat.
And have frequent meals, frequent small meals?
Smaller meals, but the main thing is just don't go to bed after a big meal. You wait at least 3 hours before you lay down. And people with severe reflux can actually prop their bed up so that they're not completely flat, and that's very effective in controlling symptoms.
Now, of the people who get fundoplasty, what's the age range, and what has been the long-term?
So fundoplication actually is performed in infants, in young adults, and in older adults. There is a subset of infants that are born with bad reflux, and so this operation can actually be done in infants, and it can be done laparoscopically in infants. The younger patients who have severe reflux disease are usually the best candidates because they tend not to want to take medications for the rest of their lives. And so particularly if frank regurgitation is part of their symptoms, they will present for surgery so they can bend over and not actually regurgitate their gastric contents.
Now, is the success rate like 95% or 98%? Tell us about that.
So the success rate is probably around 80%. It's not 100%. And part of why it's not 100% is that not all patients have been evaluated adequately to assure that their symptoms are really related to reflux. And that's why a full evaluation by a gastroenterologist and a good review by the surgeon ahead of time to confirm that the symptoms are actually reflux is critical to have a good outcome from surgery.
So now, if endoscopy is widely available now, why is it that it's not done all the time for this?
So there are a couple reasons, and one of the things I wanted to emphasize in today's presentation is that chronic symptoms should mandate endoscopy. Now the reality is endoscopy is expensive. It requires intravenous sedation, it requires going to an outpatient facility, and so we're talking about overall cost of a few $1,000s probably to have an upper endoscopy. And patients and primary care physicians often fall into the trap of, I'm taking my acid suppression therapy, my symptoms have gone away, so now I don't have to worry about it. And so that's the critical error that can be made in this disease. And it's an error because when you take acid suppression, you've treated the acid and you've prevented the symptom of acid irritating the esophagus, but you haven't stopped the reflux.
Now, if no, a lot of the primary care specialists do not take them off after 2 weeks, the antacids. Do they give them a trial of antacids, or that's not commonly done to assess?
So oral antacids like Maalox and stuff really isn't really used. They're not as effective as either of the other two options. And the current standard should be proton pump inhibitors. The proton pump inhibitors are very effective, and they should be given proton pump inhibitors for at least 6 to 8 weeks. And if they have a nice response after 8 weeks, they really should be stopped.
For 2 weeks?
Just stopped.
Period.
Period. And if the patient then has recurrent symptoms, they can be put back on medical therapy, but then they should consider and have a discussion about the potential benefit of endoscopy.
So basically, take it for the proton pump inhibitors for 6 to 8 weeks, then stopped indefinitely, and then if they have recurrence of symptoms, see a gastroenterologist.
Correct.
For further evaluation.
Exactly.
Okay. So what is the take-home message for the home audience?
So the take-home message is that this is a common disorder, that therapy is medical therapy is very effective with acid suppression, but that chronic symptoms need to be evaluated with an upper endoscopy. And the upper endoscopy is necessary to identify complications from reflux, including precancer lesions and potentially cancer from chronic reflux.
Now, I'm sure that this problem will not go away because it's common, because reflux is common. What do you think the future will mean?
Well, unfortunately, it's a big problem. Society's getting fatter and fatter. And in fact, esophageal cancer in middle-aged Caucasian men is an epidemic now. Adenocarcinoma of the esophagus, which is related to reflux disease, has increased 5-fold in the last 30 years.
Do you think this is because of diet?
I think the clear association is weight, a high-fat diet, and history of reflux.
So the take-home message is, if you have reflux and it's chronic, consider seeing your doctor and asking for evaluation for endoscopy.
Absolutely.
So thank you for having, brought all your tools here and the diagrams. Thank you for telling us about reflux and gastroesophageal disease. Hope you come back to Health Talk, and we hope that the take-home message will reach our audience and they will see their family practitioner if they have chronic reflux and seek additional care, not just ignore it and just take the proton pump inhibitors forever.
Thank you very much.